Welcome to A4 Medicine. This is a new series where we review NICE guidelines, make them easy to understand for day to day clinical practice. In today's video, we are reviewing the updated NICE guideline on hypertension in adults. Just to place it in context, the NICE NG136 was first published in August 2019, and the full NICE guidance we are using here was last updated in February of 2026. Let's go through the key points in a practical way. So, what's new in NG136? The main message from the update is that NICE is refining the pathway rather than completely changing it. Diagnosis still depends on the confirming raised clinic readings with out of office monitoring, ideally ABPM. Treatment decision in stage 1 hypertension are now more clearly based on overall cardiovascular risk, age, diabetes, renal disease, target organ damage, not just the blood pressure number alone. NICE also puts more emphasis on standing blood pressure in older adults, people with type 2 diabetes, and in those with postural symptoms. And in resistant hypertension, the step 4 pathway is clearer, especially around using potassium to guide the next drug choice. Clinic BP blood pressure is where the process starts, but in most patients, it is not enough on its own to diagnose hypertension. If the clinic reading is 140 over 9 or over 90 or above, NICE says repeat it and during the same consultation, and if needed, take a third reading, then record the lower of the last two. If clinic blood pressure is between 140 over 90 and 180 over 120, offer ABPM to confirm the diagnosis. If ABPM is not suitable or not tolerated, then use HBPM instead. While waiting for confirmation, it is important to look for target organ damage and assess cardiovascular risk. If blood pressure is 180 over 120 or higher, then think urgently about end organ damage and whether same day specialist assessment is needed. Stage 1 hypertension. So, who do we treat here? Who gets treated? So, stage 1 hypertension is not an automatic prescription decision. Everyone should get lifestyle advice, but drug treatment depends on the overall clinical picture. In adults under 80, treatment should be discussed if there is target organ damage, established cardiovascular disease, renal disease, diabetes, or a 10-year cardiovascular risk of 10% or more. We're talking about Q risk here. In adults under 60, treatment can still be considered even if calculated risk is below 10% because lifetime risk may be underestimated. In adults over 80, treatment can be considered if clinic blood pressure is above 150 or over 90. And in patients under 90, NICE advises thinking carefully about secondary causes and the long term balance of benefit and risk. Stage 2 hypertension is more straightforward. If the blood pressure is persistently in the stage 2 range, NICE recommends antihypertensive drug treatment alongside lifestyle advice, regardless of the cardiovascular risk score. Risk still matters for the conversation with the patient, but it does not decide whether treatment is offered. Shared decision making remains important, and ongoing review is part of the pathway. In younger adults, especially those under 40, stage 2 hypertension should also make us think about possibly secondary causes. Now we review the drug treatment. At step 1, NICE bases treatment mainly on age, diabetes, status, and ethnicity. If the patient has type 2 diabetes or is under 55 or not of Black, African, or African Caribbean family origin, start with an ACE inhibitor or an ARB. If the patient is 55 or older and does not have type 2 diabetes or is of Black, African, or African Caribbean family origin, without type 2 diabetes, start with a calcium channel blocker. If an ACE inhibitor causes cough or switch to an ARB, NICE also recommends us not to combine an ACE inhibitor with an ARB. So, for example, combining ramipril with losartan. At step 2, if the blood pressure is still not controlled, add a complementary drug from another class. And if a diuretic is needed, NICE prefers a thiazide-like diuretic such as indapamide when starting or changing treatment. Resistant hypertension is where precision matters before escalating treatment. NICE wants us to make sure that the step 3 drugs are already being used at an optimal tolerated dose. Step 3 means the standard triple combination of an ACE inhibitor or ARB plus a calcium channel blocker plus a thiazide-like diuretic. If blood pressure is still uncontrolled on that combination, then we start thinking about resistant hypertension. But before adding a fourth drug, NICE asks us to confirm that blood pressure is genuinely elevated outside clinic using ABPM or HBPM. Check for postural hypertension and review adherence. Only after those checks do we move to step 4. If the potassium is 4.4, 4.5 or lower, low dose spironolactone can be considered. If the potassium is above 4.5, consider an alpha blocker or beta blocker instead. And if blood pressure remains uncontrolled on 4 drugs, specialist advice should be sought. Regarding the targets, NICE keeps the blood pressure targets fairly practical. For most adults under 80 with hypertension, the clinic target is below 140 over 90. For adults aged 80 and over, the clinic target is below 150 over 90. If using home or ambulatory monitoring to assess treatment response, the equivalent targets are 5 millimeters lower. The key nuance here is postural hypertension. If a patient has significant postural drop or symptoms suggesting one, treatment should be guided by standing blood pressure rather than seated reading. And in people with frailty or multimorbidity, clinic judgment is important because overtreatment can do harm. For monitoring treatment for routine follow-up, NICE still says clinic blood pressure is the standard monitoring method. Home monitoring is supported for patients who want to self-monitor, but they should be trained properly and told what to do if readings stay above target. ABPM or HBPM can also be useful when clinic and out of clinic readings do not match, such as in white coat effect or masked hypertension. Standing blood pressure should be checked in people with type 2 diabetes, in people aged 80 or over, and in those with postural symptoms. An annual review should include more than blood pressure number. It should cover lifestyle symptoms, medicine, and adherence. Special population, this is about avoiding a one size fits all approach. In type 2 diabetes, ACE inhibitors or ARBs are used early because of renal and cardiovascular implications. In people of Black African or African Caribbean family origin, calcium channel blockers are preferred first line when there is no type 2 diabetes and if renin angiotensin system blockade is needed. NICE prefers an ARB over an ACE inhibitor. Pregnancy is a separate pathway because ACE inhibitors and ARBs are not suitable in pregnancy and need review in women planning pregnancy. In CKD, targets and drug choices may differ, especially if albuminuria is present. And in adults over under 40, always think about whether this could be secondary hypertension rather than routine essential hypertension. Lifestyle is one of the clearest NICE messages is that lifestyle advice runs throughout the whole pathway. It is not just for people who are avoiding tablets and is not something to mention only once at diagnosis. NICE recommends continuing lifestyle advice in people with suspected or confirmed hypertension and also offering healthy advice, living advice for people with raised blood pressure even if hypertension is not confirmed. The main priorities are reducing salt intake, improving diet quality, increasing physical activity, reducing excess alcohol, managing weight, avoiding excessive caffeine, and supporting smoking cessation. NICE also recommends us that calcium, magnesium, or potassium supplements should not be offered as blood pressure treatments. So we look at some common pitfalls, and most mistakes in hypertension management are process mistakes rather than knowledge mistakes. One is treating on clinic blood pressure alone without confirming the diagnosis. Another is ignoring ethnicity when choosing the first line treatment. Another is forgetting that NICE prefers thiazide-like diuretics rather than automatically using older standard thiazides when starting or changing therapy. Missing standing blood pressure in older adults or in people with diabetes can lead to overtreatment and falls. And resistant hypertension should not be declared too early. First, make sure the triple therapy is at optimal tolerated doses. Then, confirm out of clinic blood pressure, assess for postural drop, and check adherence. Pregnancy safety is another important pitfall, especially with ACE inhibitors and ARBs, as discussed earlier. So, the key take home messages, if I had to summarize NICE NG136 in a few practical rules, Confirm hypertension properly, ideally with ABPM. Do not treat stage 1 hypertension on blood pressure number alone. Choose step 1 therapy according to age, diabetes, and ethnicity. Remember standing blood pressure in older people, in type 2 diabetes, and in those with postural symptoms. Before escalating treatment, always check adherence and dosing carefully. Lifestyle advice is not optional, it should be offered at every stage. Thank you for watching. For day to day practice, it is always worth checking the full NICE guidelines alongside related guidance on chronic kidney disease, diabetes, hypertension in pregnancy, because some groups follow different targets or treatment pathways. And for treatment patient conversations, the NICE decision aid can be very helpful when discussing whether to start treatment and which option fits best. Thank you.